right, well, I think I'll get us started. So, welcome everybody. My name's Natasha. I'm one of the Senior Support Coordinators for Leukemia and Blood Cancer New Zealand, normally based in Auckland, but down here in Christchurch with you today. I have the pleasure of introducing our speaker, Dr. Rob Weinkove, who's going to be speaking on preventing infections for people with blood cancer, COVID-19 and beyond. So Dr. Rob Weinkove is the Clinical Director at the Mulligan Institute of Medical Research and a consultant haematologist in Wellington. Rob leads a chimeric antigen receptor CAR T-cell program at the Mulligan Institute and is the principal investigator for ENABLE, a phase 1 clinical trial of a new CAR T-cell therapy for B-cell lymphomas. So I'll start by handing us over to Rob. Thank you, Rob, for being with us over Zoom.
Thank you. Can I just check that you can hear me okay?
Hear you perfectly.
Right. So I'm sorry I couldn't be there in person. For those of you who weren't at the last talk I gave, I have COVID myself at the moment. I got tested positive on Tuesday and still test positive today. So we thought, given the title of the talk, it was best if I didn't come in and spread this. So I'm joining you remotely and talking about preventing infections for people with blood cancer. So some of the measures that we take, who's most at risk, and what can you do to help? And on the other hand, what doesn't help? So I'll talk about why infections are such an issue, particularly for people with blood cancers. Can't get away without covering a little bit of immunology. So I did my PhD in immunology, and that's very relevant to the reasons behind all of this. We'll talk a bit about neutropenia and chemotherapy and what measures you can take if you're neutropenia. And then we'll talk a bit about some of the more recent targeted therapies and the kinds of effect they have on the immune system. And I'm going to focus particularly on shingles, COVID-19, and some vaccine recommendations. And then we'll talk about face masks as well. So just a few points I wanted to make. And our immune system has very much evolved to fight infections. And when people look at different animal immune systems that they have, you can see this evolutionary shift in immunity as the immune systems get more and more sophisticated. I guess we don't always recognize, but what we call as blood cancers or hematologic malignancies, fundamentally, the vast majority of them are cancers of the immune system. So we're treating cancers of lymphocytes, myeloid cells, and often we're treating those with drugs that further impact the immune system, that work on other arms of the immune system, or with immune system transplants. So this whole thing is very closely tied together. And both the blood cancers themselves and the treatments that we use for them adversely affect immune system function. So it's not surprising that both the blood cancers and the treatments tend to be linked with lots of infections, probably more so than for solid cancer therapies. The other general point that's important for those of us working in the field and also for healthcare designers and funders is that as we're seeing people live for longer with blood cancers because our treatments are getting better. The result of that is we're seeing infections rise as a fraction of the issue. And I guess one example is with chronic lymphocytic leukemia, where there's a number of new treatments becoming available. And we're soon going to be getting to the point where if you're diagnosed with chronic lymphocytic leukemia, the risk of dying of the leukemia might become lower than the risk of dying of an infection. And so it's going to become increasingly important that we optimize our infection prevention methods and treatments, almost as a consequence of the fact our treatments are getting better. And we've got more people staying on certain long-term therapies, which are having an impact on the immune system. So I'm afraid I can't get around without doing a little bit of immunology. And it's going to be this one slide that I'll come back to again and again. And we tend to divide, immunologists, the studies of the people who study the immune system, divide it into two bits. And those bits are the innate and the adaptive immune system. And what we mean by the innate immune system is the cells, the immune system that we're kind of born with. This is partly structural, so it's the structure of our bodies, like the barriers that form our skin, and the mucosa, which is the lining of our gut and the lining of our lungs. And ancillary systems, like you might not be aware, but inside your lungs are these tiny hairs called cilia that help propel the gunk out of our lungs, and then we can cough it out. These are all parts of our innate immune system. And also certain cells are part of our innate immune system, including ones that you might hear your hematologist talking about quite often, called neutrophils. And the reason we're so obsessed with neutrophils is neutrophils are our first line of defense against bacteria that get into our body. Their cells are very numerous. They don't last very long. They only last a few days inside the body. And they've got specific receptors on their surface that can recognize particular patterns on bacteria and engulf them and try and kill them. So the innate immune system is really critical. It's very fast. It's always there. It's there. We're born with it. And even very primitive animals have an innate immune system. And the innate immune system is absolutely critical for our defense against bacterial infections, also fungal infections, and in fact also parasitic infections. But parasitic infections aren't such a big issue in immune compromised people because our Western lives mean we don't have such issues with parasites than we used to. Maybe unless you happen to travel to Africa or an area that's got a lot of malaria. But you can't really survive for long without an innate immune system. So when children are born with these very rare conditions where they have no neutrophils, they get sick very quickly and need to go on to special treatments and intensive very, very early in life. The adaptive immune system is the other part of that, and that's a system that learns. So if you think about me recently a few days ago, but if you've had a sore throat or COVID, one of the symptoms you might get if you get a sore throat is you might notice these enlarged lymph glands around your neck that become swollen and tender, and go up and enlarge and a bit sore for a few days, and they shrink back down again. What you're feeling then is your adaptive immune system in action. What's happening is lymphocytes are flooding in, trying to recognize this new infection that they haven't seen before. And inside those lymph nodes, there's a kind of survival of the fittest happening. The immune cell, certain of the lymphocytes are expanding in number, trying to recognize the infection. And believe it or not, those lymphocytes, as part of what they normally do, they can rearrange their DNA and create specific mutations and actually create new receptors on their cell capable of recognizing that infection. And those are the cells that some of the cells that go on to make antibodies, for example, and give us long-lasting infection. So it's a slower system, but it can allow our body to adapt and learn to recognize new infections for the first time and then give long-lasting protection. And the adaptive immune system is really important for our responses to viral infections in particular. So it's often the target of vaccines. When you have vaccines, you're trying to initiate an adaptive immune response and teach our immune system to recognize this thing as foreign. And that's not present in very, very primitive animals. That's something that evolved a little bit later. So these are the two principal arms of our immune system, and different treatments affect these arms in different ways, and that has some impact on the type of infections that we can be susceptible to. So chemotherapies are treatments that have been around for quite a long time, since about the 1950s. And what chemotherapies, or at least cytotoxic chemotherapies, tend to do is they tend to cause DNA damage. They tend to affect the ability of a cell to replicate its DNA, which is something that happens whenever a cell tries to make copies of itself. And the result of that is the cells inside our body that try to make copies of themselves most frequently are most susceptible to chemo. And so that often is very, very selective for the cancer itself. But there are a handful of other organs within the body where cells tend to proliferate quite frequently. And those include the bone marrow. And so a lot of chemotherapies cause low blood counts because they temporarily damage the bone marrow, and also the lining of the gut. The lining of the gut replenishes itself quite frequently. So a lot of chemotherapies cause things like diarrhea or nausea or sore mouth, that sort of thing. Now, those cytotoxic chemotherapies, if you've had some of you in the audience will have received or maybe are receiving cytotoxic chemotherapies at the moment, they will often cause this period of neutropenia where the neutrophil count goes low, often beginning about 5 days after the first dose of chemotherapy, and depending on the strength of the chemotherapy, lasting for 5 days to maybe even several weeks in the case of acute myeloid leukemia induction treatments. And how low the neutrophil count goes and how long it stays low for depends to a large extent on how intense that chemotherapy is. And this particular combination with chemotherapy of causing a very low neutrophil count, but also damaging the lining of the gut, leads to a particular problem, which is that the bacteria that already reside normally within our gut can get across into the bloodstream. And when they're in the bloodstream, there's no neutrophils there to clean them up. And this can cause neutropenic fevers or neutropenic sepsis. So that's the thing we often worry about most. If you've been on chemotherapy and received those warnings to monitor your temperature and come into hospital immediately if you have a fever above 38 degrees Celsius and you have to go straight on intravenous antibiotics, it's this concern about neutropenic fevers and people suddenly getting very unwell out of nowhere because there are no neutrophils to protect us against the bacteria that can get across from the gut into our bloodstream. Also, with particularly deep neutropenia lasting particularly for more than a couple of weeks, there's also a risk of fungal infections, and that can either be some of the fungi that are already within on our skin or in our nose, like the thrush, Candida, or the fungi that we're breathing in, particularly if we're working with dusts and soils in the environment. So there's a lot of fungal spores and hyphae inside soils, for example, and we breathe them in when we're outdoors, particularly digging around in dust and soils. And they normally, if they got into our lungs, we'd reject them and get rid of them again, but they can settle in the lungs if you've got a severely low neutrophil count and gather in there and cause infections. So this is why I've got this particular advice about very rapid attendance at a hospital for antibiotics if you're severely neutropenic. And by that I mean neutrophil count less than 0.5. When the neutrophil count is greater than 1.0 or higher, the risk of neutropenic fevers probably isn't significantly increased. So what can you do to prevent infections or even detect them earlier? The first thing is, hopefully, if you're getting these intensive kinds of chemotherapies, we try to give people some chemo patients, so some leaflets about this and sessions often with a nurse or community oncology nurse to go through what to look out for, and often give people a little card to help get them through our overcrowded emergency departments a little bit faster. And that's because if people do develop a high fever after these strong chemotherapies, the goal is to get intravenous antibiotics in within an hour of presenting at hospital. So obviously a 6-hour wait in the ED waiting room is not very helpful for that. We do recommend that people have a thermometer and know how to use it if you're in this situation. There's loads and loads of thermometers out there after COVID, particularly lots of these sort of digital ones that work from a distance and get your temperature via infrared. They can be quite good, but just a bit of advice if you're buying these kinds of things is to try and seek some kind of quality mark on those devices, because there's a lot of ones from companies that you haven't really heard of before. So one option is to seek an FDA cleared device. That's the Food and Drugs Administration in the US, or CE, which is Council of Europe mark. Those are two quality badges that just indicate that those devices have been through some kind of quality process to make sure that they are properly capable of detecting fevers with reasonable accuracy. I mentioned this earlier, and I think I do try and emphasize this for very severely neutropenic patients. Sometimes, I know what it's like when you're off work and you can't go into work and you're at home. You might want to get some jobs done, get some DIY done, maybe do the garden. But you need to be quite careful if you're severely neutropenic, particularly if your neutrophils are less than 0.5, about these composts and soils. On the right, you can see a typical bit of soil. And you might, if you look carefully, certainly if you look with a microscope, soil is full of fungi. It doesn't matter about inhaling those if you're if you've got a normal neutrophil count, because you'll reject those fungi that you breathe into the lung anyway. But you do need to be very careful. So either avoid that sort of gardening work altogether while you're neutropenic, or if you absolutely must do it because it's very important to you, you really want to be wearing a very, very good face mask. I'll talk a bit more about face masks later, and wear gloves and wash your hands after you've worked out there. Similarly, sort of wet, particularly moist dusts like sawdusts and things can actually contain quite a lot of fungal spores as well. So if you're into DIY, be aware of that while you're severely neutropenic. If you've got a PICC line in, obviously that's a potential port for infection. So hopefully you've taught how to look after that line site. As you may know, your doctors may and nurses may advise you to use GCSF or long-acting GCSF injections. These are injections to help bring the neutrophil count up faster after chemotherapy. So they don't necessarily prevent the neutrophil count from going down, but they might shorten the period of severe neutropenia, limits the amount of time you're prone to infections, and they might mean that the low point isn't quite as low. So they're very useful medicines that we often use with many chemotherapies. And then for some people, and we do this on a risk basis, we may recommend preventative antibiotics to prevent infections, or antifungal medicines to try and prevent fungal infections. Just one comment. I've noticed a few people say, well, I won't get an infection because we're staying at home and wearing a mask and not seeing people. Most of the infections that happen during severe neutropenia are not from other people. So it's actually the bacteria already on your skin or already inside your gut getting into your own bloodstream. So while you might be able to avoid the complication of getting COVID or a cold or a flu by not seeing other people, you can't avoid neutropenic sepsis by staying at home. It will, if it's going to happen, it can happen anyway. We have around 2 kilograms of bacteria harboring our gut in our gut, 100 trillion bacteria each. You can't avoid the possibility of those getting into your bloodstream if you're severely neutropenic. So while you can avoid some types of infection by staying at home, you can't avoid bacterial infections entirely. One question that's often asked, and we often don't get right as clinicians, is, okay, so if a lot of these infections come from the gut, can we reduce the chance of these infections by changing our diets? So can we avoid certain foods or do things with our diet to avoid those infections? And the answer we think now is not really, actually. So there was a vogue over various times for trying to do this. At one point, there was a tendency to try and give people antibiotics, special antibiotics by mouth that don't get absorbed into the bloodstream, to try and decolonize the gut of bacteria before chemotherapy. Doesn't work. All that happens is you disrupt the normal gut bacteria, and there will always be some bacteria in there, and a greater fraction of the ones that are left are now resistant to antibiotics or are nastier ones. So that doesn't really work. That's been discounted. And we used to advise some quite restrictive neutropenic diets, but those have now been shown, including in a study released just a couple of months ago, not to reduce the infection risk during severe neutropenia. So very restrictive diets don't appear to be very helpful. So the advice now is really food safety guidance while they're neutropenic. And that guidance is actually really, really similar. It's basically the same as what we recommend for pregnant women. And it's basically around avoiding food poisoning bugs. So things like listeria and Campylobacter and Salmonella, stuff like that. So the old advice that you couldn't have a salad if you were neutropenic is, as far as I'm concerned anyway, gone. You can have salads, you can have raw vegetables and things like that. You should, however, wash them thoroughly, because what you don't want is soil attached to those, because it's the soil on those that could contain listeria, for example. So yes, you can have most raw fruit, raw vegetables, you can have unpeeled fruit, but it should be washed thoroughly. You should avoid raw or partially cooked meat and fish. Avoid raw eggs. We recommend avoiding unpasteurized milk and milk products, avoiding moldy cheeses. The question was as to how much risk there is for moldy cheeses, but nonetheless, it tends to be the advice. And then the other bit of food safety advice which I think most of us don't adhere to very well, is be careful about storing foods have been partially eaten in the fridge for more than a few days. And the reason for that bit of advice is there's a handful of bacteria, and the main one is this one called Listeria, that are able to grow at refrigerator temperatures. And that's particularly the case if your fridge doesn't work that well and isn't keeping it all the way down at 4 degrees Celsius, which is meant to be the gold standard. If your fridge is only keeping it temperature down at 8, and there's that bit of ham that you carved yourself that's been at the back of the fridge for 7 days, Listeria is the kind of thing that could continue to grow while it's in there. So while you're severely neutropenic, you should probably be super careful about keeping open partially eaten food in the fridge for more than a couple of days. And I know a lot of us are guilty about that. I don't know how long that pesto has been in there or that mayonnaise jar. So be a bit careful about that kind of stuff. Food safety advice, but we don't really need to be super restrictive. That's because some good randomized clinical trials now have shown they don't really help in terms of infection reduction. So I want to come to targeted therapy. So increasingly, the treatments that we use now are no longer conventional chemotherapies, or they supplement conventional chemotherapies with other drugs that are maybe a little bit more targeted towards the blood cancers. And the types of medicines include antibody treatments like rituximab or obinutuzumab. These are funded and used quite commonly. Daratumumab, once it's funded, at least for myeloma. Bortezomib is used very often for myeloma, as are steroids. We've got some drugs there like venetoclax and ibrutinib, ruxolitinib used for myelofibrosis, and then some of these newer immune therapies like CAR T-cell therapies and bispecific T-cell engagers. And these can sometimes cause neutropenia in their own right, and many of them do, but often either only occasionally or for not such severe neutropenia. But what they do is they affect the cells of the adaptive immune system. They affect our adaptive immune system's ability to respond to new infections like viral infections, to sustain our protection against viral infections, and they affect our ability to respond to vaccines. So what you can see with these treatments is things like reactivation of viruses that you might have already had before, like cold sores or shingles, which is a reactivation of the chickenpox virus. Some people carry hepatitis B and it can become reactivated during these treatments. They do have some impact on your protection against certain kinds of bacterial infections. So people can have a risk of things like pneumonia and cellulitis and urine tract infections, usually treated with tablet antibiotics. And people can get more severe versions of viral infections like flu and, as I'll come to, COVID. So what things can you do if you're getting these kind of more targeted therapies? Let's say you're not severely neutropenic, but you are getting some of these targeted treatments. So we tend to do this behind the scenes, but we would always check hepatitis B status before treatment. And many people would be asked to have, if it looks like they'd had hepatitis B in the past, which you may have picked up decades ago without knowing about it, you may be advised to take an antiviral to prevent that reactivating during or for some period after your therapy. It's a really good idea. I'll come to this in a moment. If you've got a disease that might end up being treated with these conditions, it's ideal to get vaccinated before you start treatment. So I do tend to recommend that people with early stage chronic lymphocytic leukemia or asymptomatic myeloma or even MGUS, not a bad idea to look at optimizing your vaccinations. And that's because once your condition does need treatment, and bearing in mind when it does need treatment, you might not get that much notice. Once you start on therapy, your ability to respond to vaccinations will be diminished, whereas you won't necessarily lose your existing vaccine responses. So if you've got a condition that you're on monitoring for in case it needs treatment in the future, it could be a good idea to get up to speed with your vaccinations, and that could lead to benefits later on after your therapy, even in years to come. I'll come on to that in a bit later. For some of these treatments, we will often use an antiviral medicine called valacyclovir that can prevent shingles, which I'll talk about in a moment, and cold sores. And for some people, they might be so prone to recurrent bacterial infections, we might either give a daily antibiotic to prevent those or give infusions of antibodies from healthy people as a way to prevent those infections. And in this sort of situation, If you do get an infection, let's say that you're not severely neutropenic, but you're on some of these therapies like ibrutinib or venetoclax or myeloma maintenance treatment, but not neutropenic. You don't necessarily, in that case, if you're not known to be neutropenic, need to rush into the emergency department with every fever. But if you've got a cough with green or yellow phlegm, or a spreading skin infection, or a possible urine tract infection, you don't want to sit on it and wait. It's really important to get medical advice. And I usually recommend same-day medical advice. Doesn't necessarily have to be via one of our overstretched emergency departments. It could be in one of those out-of-hours centres if you have one, or a GP if you've got a GP with decent availability. I accept this is not always straightforward. And for some centres, hospital blood and cancer centre day units may be available to see people at short notice at certain times. I would point out that many blood cancer therapies involve more than one agent and might affect both systems to differing degrees. So what I've talked about isn't necessarily mutually exclusive. For CLL treatment, people might be on bendamustine chemotherapy with rituximab, and the bendamustine hits both systems and the rituximab hits mainly the adaptive system. So to some extent, many blood cancer therapies affect both at different times. I want to just talk about a couple of specific infections. I guess maybe this is because of things that I've seen recently. Shingles, I suspect some of you in the room may have had shingles. It's a common infection, and it's not necessarily a new infection, so it's not necessarily something that you catch. So most of us have been exposed to chickenpox in childhood, and you actually never completely get rid of that virus. It actually lies dormant within some cells in our spine, our nerve cells at the root of our spine. And that virus, when it's there, doesn't cause any problems. But when our immune system is weak, it can become reactivated. And the reason that's important is because it's a little bit odd. It's a bit unlike other infections. So it comes up with a localized rash, usually restricted to one side of the body. In a strip. Actually, the word shingles comes from the Latin singular meaning belt, but it usually sort of stops at the midline. So it could be across the back and the chest, it could be across the face, potentially involving the eyes. It can be around the buttocks. And it comes up as a sort of reddish rash, and then it forms these little blisters. And so it might not fit your normal criteria of, oh, hang on, this is definitely an infection, needs something doing. Later on, it can crust over. It's still important to recognize, and it's important to get on treatment, because some of you in the audience may well have had shingles and could testify that it can be very painful both at the time, but also some people get nerve damage from it, and people can have nerve pain that goes on for months or years after the episode. And that can be reduced by getting promptly onto antiviral treatment if you have it. The risk of shingles can get really high after certain blood cancer therapies. For example, if you have something like bortezomib or rituximab, the risk of getting, without anything to prevent shingles, about 1 in 5 to 1 in 10 people without prevention will develop shingles while they're on those treatments. So that's quite a high rate. So generally, for almost everybody on bortezomib, or for almost everybody getting rituximab, I would be advising an antiviral to prevent shingles reactivation during treatment and for some period afterwards. Now, you can reduce the chance of getting shingles by boosting your immunity against that virus with a vaccine. And this is something that's relatively new, because a couple of years ago, the only vaccine that we had for shingles used to be called Zostavax. It's actually a live virus that contained a live version of the varicella virus. And even the weakened version of the virus, it could actually cause illness in people with blood cancers. So the general wasn't any vaccine option for people with blood cancers. Well, now there is. The new vaccine, which is called Shingrix, is safe for immune suppressed people and can be used, and you could opt to have that. I'll talk about that in a moment. And then we can use these antiviral tablets, people at very high risk, to prevent infection. The main one is a daily tablet called valacyclovir. The alternative is a typically twice daily tablet called acyclovir. And then, as I mentioned, if you're immune suppressed, do take shingles seriously. I do recommend getting same-day medical advice and getting promptly onto antiviral medicines to help prevent it spreading or getting worse. COVID, we all remember those days of hiding out at home. and gathering toilet paper around us to make sure we had all our supplies. And it seems like a dim and distant past, but this virus is still with us, as I can testify. Didn't particularly enjoy my second round infection this week, but fortunately not severe. But it's still around, and it's still causing problems, and it's still of concern for our units and for you as patients. So I'm just going to say a few things about it. Every now and then you get a horror story, about the latest variant. But the reality is that it is very, very clear that the newer variants, ever since the Delta wave passed, have been becoming less severe. And that's partly intrinsic to the virus. The virus has evolved to become more infectious, but less severe. And it's partly because we have more immunity, both from vaccines and from prior infections. And although people with blood cancers often have diminished ability to respond to vaccinations, there is some ability to respond to vaccines. So even some degree of protection is better than none when it comes to preventing the most severe manifestations of disease. And I suspect that most of you are, and I think most people are feeling more relaxed about being out and about, even with blood cancers in the era of COVID-19. But just to reassure, if you go and look up in the literature, there are some frankly terrifying statistics about COVID-19 among people with blood cancers out there, largely relating to the first and second waves in places like Europe and the US, before there was any vaccine available, and before we moved into the sort of era of Omicron onwards, where it became less severe. We are not seeing anything like those issues now. It's quite rare that we even have to admit a patient for COVID-19, let alone have a patient go into intensive care. Not unheard of. It is happening from time to time, but it's quite rare. And certainly we've seen that in the hospital setting. Vaccines do appear to help, and people with blood cancers may need more doses of vaccines to get as much immunity as possible. And they certainly, even though the vaccines are sort of lagging a bit behind where the virus is at, they do seem to have some role in preventing the most severe manifestations of the disease. So even partial immunity may not stop you from getting symptoms, but it makes it much less likely that you get really sick and need to go to intensive care or need a ventilator or anything awful like that. Nonetheless, if you're immune suppressed, I do recommend that you test yourself with a rapid antigen test. And it's a good idea to have some of these at home, so that you gather some. I'll give some links later on. You can get free rapid antigen tests. Still, I believe it's a bit awkward to get hold of them, but you can. And if you're immune suppressed and eligible, I still strongly recommend Paxlovid. So we had various medicines. We had antibody treatments like Evusheld, but most of those have become less effective because the virus has changed. But fortunately, the main tablet antiviral medicine for COVID-19, called Paxlovid, appears to remain effective. It's not affected by the mutations that the virus is making on its surface to evade immunity, and it still seems to be very effective and a very useful drug. So Paxlovid, everybody's eligible if you're age 65 or over, so that's easy. If you're under 65, you may still be eligible, so the various groups are eligible, but the most relevant one to most patients with blood cancers is the eligibility criterion that says immune compromised and not expected to reliably mount an adequate immune response to COVID-19 vaccination or and so that's a little bit of a complex definition, and you have to sort of springboard from one definition into another information sheet to find out what they mean by that. But that definition of immune compromised I've given some bullet points of some of the things that meet that criteria below. But basically, it's most blood cancers while on treatment, under follow-up for chronic CLL or lymphoma or myeloma or Waldenstrom's, a bone marrow transplant, autologous or allogeneic within the last 2 years, or any sort of B-cell depletion or rituximab in the last 6 months. There is a little bit of clinical flex around these criteria. You'll notice that some things are missed out. So you've got early myelodysplasia just under monitoring and not on treatment, you wouldn't be eligible. But your risk probably isn't that high. And what I would say is that if you meet those criteria, try and get into Paxlovid. And in fact, you can get Paxlovid directly from pharmacies, but they may have difficulty interpreting these criteria. Just beware if you take Paxlovid, some people do get better and then get recurrent symptoms a couple of weeks later. And it's a good idea to perhaps have a oxygen saturation meter at home if you are significantly immune compromised, just to make sure you're not getting low oxygen levels, or have some of these smart devices, smartwatches have oxygen saturation meters built into them these days. And there are some useful links. Hopefully the presentations might be being shared, so you may be able to get hold of these from those, but it is possible to get free rapid antigen tests. Should I wear a mask? I'm going to go through quickly as I'm running a bit over, but just to mention, it is, I mean, after a lot of messing around early on, it's clear that this virus is airborne, and it can actually hang around for hours in aerosols. And face masks probably are largely useful as a sneeze guard, basically, and that they sort of keep it in if you have a big sneeze and reduce the number of airborne particles, aerosol particles floating around with the virus inside. Should I wear a face mask? Well, I'd say most people aren't these days, but if you're at particularly high risk, so currently being treated or within a few months of finishing treatment, or particularly if you recently bone marrow transplant, particularly allogeneic transplant, you probably are quite high risk and should consider it. In contrast, if you're not currently treated or previously treated and in complete remission, or you've got CML and a kinase inhibitor, your risk is probably not much elevated above the background population, bearing in mind maybe at some risk anyway from other conditions like age or smoking status. And to be honest, a lot of the controversy is that real life studies of masks have shown very mixed results. So while mask mandates as a public health policy seem to reduce infections when everybody was wearing them, if you randomize individual people to wearing a mask when most other people aren't, pretty mixed as to how effective that is. And that's probably because there's not brilliant compliance, and perhaps the mask quality might not always be that good. The other thing to point out is newer COVID-19 variants appear to be a bit more infectious than the original ones. So look, masks probably reduce virus infections if everyone wears them. And so there's probably still a role for them in blood cancer wards, for example. At an individual level, the benefit of masks is probably quite limited. There's probably some, but it's not huge. And I would just say that's fine to wear them, but at least as important to make sure you've got a plan for managing the event of a COVID-19 infection. And just say, if you're going to wear them, going to bother with wearing them, you may as well get a good N95 type mask or one of the equivalents respiratory standards that are put there, P2, FFP2 or KN95. They're all roughly equivalent mask standards. So if you're high risk and you're highly averse to that risk, and you may have your own reasons, you may have previously had severe COVID-19, you may have or know people who've had long COVID, you may have or know people who've died of COVID. Those would be strong reasons why I'd probably be particularly averse and be particularly concerned. Vaccines, what can you do? Well, you can ask for pneumonia vaccines. So most of us can get the pneumonia vaccine called Prevnar 13. It's a conjugate vaccine. And that's funded pre-chemotherapy if you're immune compromised. The booster dose, which is ideally given 8 weeks later, is only funded post-chemotherapy. So you can either pay for it to get the booster now or wait until you've had chemotherapy. And then further boosters can be given later. Now, this shingles vaccine is available in New Zealand, but unfortunately it's only funded at the age of 65. So not over and not under. And it is specifically licensed for younger people with impaired immunity. So you can choose to self-fund it if you want. It is quite expensive. I think it's around $600 for both doses. The cost will depend on your GP surgery. So if you had early CLL or MGUS and you're pre-treatment, you may want to consider getting the shingles vaccine. If you're already on treatment, it's probably better just to take the antiviral if you need that. And then COVID-19 recommends staying up to date with the vaccines and flu vaccines as well. There are specific vaccine recommendations after bone marrow transplant, which I'm not going to go into here. A few words to travel, because now people are traveling again. We're getting a lot of questions about that. Just I generally tell people to check their travel insurance terms carefully. they're very good at taking your money and not so good at paying out if you make a claim. So just really check. You may well find there's either lots of exclusions, or they'll ping you for not fully declaring a health issue. If you've got a blood cancer, you may find it difficult to get fully comprehensive insurance. If you were going to take risks, consider traveling to countries with a reciprocal health arrangement like Australia or the UK. The cost of healthcare can be very high in the US if you get caught out. Check your medicine supply, check your vaccine status. Just be aware that some countries require certain vaccines that are live vaccines that can't be given to people with blood cancers, like yellow fever vaccination. And so some people need special exemption letters to say that they can't have that vaccine in order to get in. If you're going to a part of the world with malaria prophylaxis is particularly important if you've got a blood cancer. And I tend to suggest people carry a copy of one of their clinic letters with them in case they have to seek medical advice while overseas. It's a good way of letting doctors there know what your diagnosis is and who your treating centres are. And for some people, there may be a role for emergency antibiotic supply. So to conclude, blood cancers and their treatments predispose to infection. If you have the opportunity, and we don't always get that chance to get vaccinated before treatment, you may have to follow neutropenic advice. There may be preventative medicines. Good to have a COVID plan, to testing for COVID-19 if symptoms develop, and getting Paxlovid if you can. Prepare for your travel. Look, I'm just aware that our healthcare services are a bit strained, and it may be hard to see a GP sometimes, or you see somebody who can be a bit dismissive of symptoms. And the problem is that there's a lot of advice, with coughs, for example, that they don't need antibiotics. And if you're severely immune compromised, you may need to advocate for yourself a little bit. I try and put on patients' letters, if relevant, low threshold for treating antibiotics for suspected infection. So you may need to advocate for yourself a little bit there. And look, happy to take questions.
Thank you very much, Rob. You've done an amazing job of squeezing so much into such a short period of time. We really appreciate it. So we do have some time for questions, and Deb will come to you with the mic if you've got any. So did we have any questions from anyone? Yep, one here.
Thanks, Rob. Just probably the fact that you didn't mention anything about it probably says as much, but post bone marrow transplant, stem cell transplant, what sort of vaccinations you need that you may have lost immunity to that might have been childhood vaccinations?
Yeah, so I didn't mention it mostly because if you're going through a bone marrow transplant, you'd have many of us would have a bone marrow transplant coordinator who'd address this. There's actually a specific information sheet about that was released by the Immune Advisory Centre of New Zealand. Actually, there was a link to it on one of my slides, so I can nip back to it and put it up while we're getting the next seeking the next question, I think. Oops. But it's quite complex. It's quite an involved series of vaccines, and I didn't put a link to it, but there's an Immune Advisory Centre fact sheet from June 2023 called "Immunisation for Adults Post Hematopoietic Stem Cell Transplantation," and I would say that generally the transplant centres will be aware of that recommendation, and would usually, at least at our centre, we would let the patients know and write to the GP with the recommendations at the time.
Great, thank you. And we got another question here.
Hello, Rob. It's Denise from Dunedin. I'm just asking, after the shingles, have it for 10 months, pain deep down and going down to my foot, can that actually be just the nerve pain rather than?
Yeah. So what we think it is I can't specifically speak to your symptoms, so I'm not going to sort of give medical advice here, but what we think happens is that after you've had an episode of shingles, after that virus has sort of reactivated along those nerve roots, that causes nerve damage, and it's that nerve damage that causes the ongoing pain afterwards. And as you've mentioned, this is the problem with shingles, is it can be really debilitating. And the nerve pains, some people will have significant nerve pain for many months or years after the event. And I think I've never experienced it, but I've certainly seen a lot of patients be very debilitated by shingles. And I think I think it would be really great to have Shingrix vaccine routinely funded for people with blood cancers. And I think there probably is some role in lobbying for that. I'm expecting that Shingrix vaccine, the criteria will be broadened out in time. But at the moment, it's quite restrictive. They only offered it as a straight swap for Zostavax as part of the national program. So you can only get it funded if you're exactly age 65 right now, which seems a bit crazy. So yeah, it's probably ongoing pain, and that then needs its own. There's separate ways of managing that. GPs are quite accustomed to managing that. It's called post-herpetic neuralgia, and that's because shingles is chickenpox virus is a type of herpes virus, and it's basically the ongoing pain that occurs after the infection. But yeah, I can only empathise because I've heard it can be really quite disruptive, really very and persistent.
Thank you. And one last question just at the front.
Hello, it's Nigel Patton again. You haven't mentioned 3 infections that are CMV, pneumocystis, and toxoplasmosis, and we usually associate these with the profound immunosuppression in the early period following allogeneic bone marrow transplantation. But I in the new era of BiTE antibodies and CAR T-cell therapy, the use of steroids in the post-treatment period, how serious are these infections in with those types of treatment?
Yeah, so I didn't go into those specifically for a couple of reasons. One of them, first, the CMV reactivation. As you know, it's generally a problem after allogeneic transplantation, and we would always use monitoring and preemptive therapy. And it's not really something that patients can watch out for themselves, because there's no very sufficiently specific symptoms to watch out for yourself. Something really needs close clinician input to detect. Pneumocystis is a strange one. It's this for everybody else there. It's a particular type of lung infection. I can never remember whether they've classified it now as a fungus or a bacterium, but it's a particular organism, a protozoan organism that can cause lung infections. And we tend to, for some people, give a daily antibiotic that has activity against that particular lung infection. We do automatically give that antibiotic to people who are most at risk of that infection. And again, seeking prompt medical advice for symptoms of a lung infection would usually lead to that being detected and treated. Then toxoplasmosis, oddly, I don't actually recall having seen that since I've become a consultant. So since we tend to give cotrimoxazole to those most at risk, we probably are covering it. So one thing is, as new infection treatments come along, we have to adapt our infection prevention methods. For example, after CAR T-cell treatment, we give all patients a daily antibiotic called cotrimoxazole for the first year after treatment, and most patients will develop low antibody levels, an expected side effect of the therapy, and need immune globulin replacement. But those things will generally be automatically recommended as part of your treatment scheduling. But Nigel's right, as we develop new treatments, we'll find new things that affect infections and issues that arise, and we'll identify new ways of managing those. And indeed, I'm part of a group that's running a platform trial, planning a platform trial to look into ways of preventing infection among people with low antibody levels due to blood cancers. So I think this is a growing area of need, and our new therapies are going to continue. So thanks for bringing that up, Nigel.
Great. And I think that brings us to the end of our questions. So once again, on behalf of all of us, I just want to say a huge thank you to you, Rob, for your time. especially when you've not been well. You've made this time to be with us virtually today, and we really appreciate it. So let's give a round of applause for Rob.
Very much for the opportunity to speak, and hope you enjoy the rest of the day.
Thank you, Rob.